Rahman Rahim. This is Haidar Yahya, the marketing manager of Asino in Iraq. First, I would like to welcome all of you and thank you for your attending our webinar. Then I would like to thank the Iraqi Society of Gastroenterology and Hepatology, as well as our distinguished speaker and moderator for their time and effort to enrich this webinar. The moderator of this webinar is the well-known Dr. Jassim Al-Maliki, the president of Iraqi Society of Gastroenterology and Hepatology. Dr. Jassim is a consultant gastroenterologist at the Gastroenterology and Hepatology Teaching Hospital in Baghdad. Dr. Jassim, the floor is yours.
Thank you for your presentation. Thanks for the Asino company for their efforts in presenting this event. It is the second event for Iraqi Society Gastroenterology and Hepatology during this area. After we use a webinar to enrich our knowledge about different parts of gastroenterology. I would like to thank all the attendees and participants from the Iraqi Society, and also the speakers, Dr. Anthony and Dr. Ali. And we would like to highlight to our attendee, if they have a question, they may type it in question and answer bar, and our speakers will answer them in the question and answer session at the end of the webinar. Our first speaker is Professor Anthony Emanuel. He's a professor of neurogastroenterology at University College London. He is also a treasurer at the British Society of Gastroenterology. He is a fully accredited GIT endoscopist with more than 6,000 procedures. His lecture is Modern Management of Constipation. Professor Anthony, the mic is yours. Many thanks for Professor Anthony for his rich presentation.
Thank you very much indeed for the invitation. Thank you to colleagues in Iraq for introducing me. Thanks to Asino for making this happen. And above all, thank you to all the delegates for taking time out of your evening. And I want to spend half an hour, if that's okay with you, presenting on a topic which I think is often overlooked, but which is very important to our patient group. And I will try to share my screen with you, so I will make sure that that's ready to go. And hopefully that's, if somebody can just confirm to me that you can see the screen, then I'll carry on. Is that visible? Can I get a thumbs up from somebody? Is yep. My screen visible?
Yep.
Lovely, thank you very much indeed. So I say thanks again for joining, and let me present, if I may, some practical advice. I don't want this to be a theoretical session, but I'm happy to answer any questions about this. But what I hope that you will leave at the end of this half an hour, and obviously I'm delighted to be sharing the time with other colleagues who also have different insights, is a kind of a practical approach to this problem group, because this is a symptom which is often quite hard for our patients to express, and sometimes hard for us to deal with, because we feel like it's all one thing. What I want to try and persuade you of is that there are some simple symptom assessments we can make, not by doing fancy, complicated tests, but to help us understand our patient group. So I should confess that actually you may be under here on false pretenses, because I'm not, strictly speaking, a gastroenterologist originally. I was a neurologist in my training, and I became a gastroenterologist almost by mistake during my MD when I went to St. Mark's. And I started being trained by John Leonard-Jones and Michael Cam. And I now spend my working week in London, as you heard, spending half my time in this modern-looking building on the top, where I do my gastroenterologist practice, and the other half of my time in this academic neurology hospital on the right-hand side with the red brick, both of which are in the centre of London, where I'm happy to work. Now, if we think about constipation, we begin always by thinking about definitions. And my problem is that if we use the definitions that are given to us, they're not very useful as a clinician. So if you use the Rome 4 definition, it has this list of things of 25% of time with this, and 6 months of that, and 3 weeks of this in the last 3 months. You know, no one that I know in clinical practice uses this, because it's too burdensome. It's only useful, I think, for clinical trials. So we often have a more practical description, which is essentially around difficulty or infrequency in bowel motions. But even that simple description I think misses some problems. So I think there's a problem with these very formal definitions, that they're too cumbersome, they're not useful, they're not practical. And these simple definitions will miss out some of the burden that our patients suffer. Now, I want to try and spend a few seconds, if I can. I said I wouldn't do a theoretical talk, and you see a slide like this and think, oh, he's broken his promise, he's giving us theory. But what I want to try and persuade you of is that actually we've got to think about these functional conditions along a spectrum rather than thinking of them as something else. So I think the spectrum is that you have patients who have variable bowel frequency, and that frequency is associated, we know, with variable consistency. So everyone is familiar with the Bristol stool type, and we know that that correlates very, very well with transit. There's good data showing that the more firm the stool, the nearer type 1 it is, the slower the transit. And there's a linear correlation between stool type and transit time. So there's a vertical axis of increasing constipation, where the loosest down here is diarrhea, and at the top end is constipation. But I also want to remind ourselves that pain is another dimension that we should think about along the other axis. So it's not that everyone with functional condition has pain. We know that actually about 2/3 of patients with functional diarrhea and about 50% with functional constipation don't have pain. So it's only when you have pain, and when that pain is associated in terms of timing with bowel emptying, that you can be said to have IBS. So first thing I want to say is to differentiate between the idea of pain and bowel frequency as being different concepts. And clinically, we need to have that in mind, because if we have a patient who has IBS, i.e. pain related to bowel dysfunction, we have to manage them differently to how, or think about them differently in terms of their etiology to how we would manage a functional constipation. So we know these are prevalent problems. There are many, many surveys out there. This is one of the many surveys that I'm showing data here from US, UK, and a variety of European countries, Brazil and South Korea. And what you see is that between 10 to 15% of the population are defined as constipation, depending which criteria. So this is well known to you. That's not so interesting, but I just present that as background to this. But what I want to also persuade you of is that the patients are out there, but they present in a way that we may not recognize. So this is a different survey from North America, and there are 2 or 3 ones like this. And it makes a very important point that, first of all, our patients present in a variety of symptoms. So we always document their bowel frequency in red. You know, we're scientists, and we like to think, oh, well, we're going to document the frequency, the number. But actually, for our patients, the number is not so important to them. It's the 5th or 6th ranking symptom. They're much more bothered by straining, by gas, by bloating, by hard stool, by difficulty emptying, by having to use a finger. Those things are much more burdensome for our patients than the frequency. And so the first thing I want to say then is that simply chasing an extra bowel movement per week is not going to make many patients happy, because their problems are not just about frequency. Other thing about these symptoms is that there are many, many symptoms, as you can see. It isn't just difficulty, it isn't just infrequency. That's why I said that the practical definition can miss out some of our patients. So there are a variety of symptoms, and there are the maybe slightly atypical sensory ones, which are the most troublesome for our patient group. So let me try and spend the next 5 minutes in a practical way trying to explain how symptoms can help us to understand the underlying pathophysiology. Because I believe that if you take the patient and they have their symptoms, you can use that to explain the pathophysiology, and then you can use the pathophysiology to then give specific treatment around laxatives and so on. So what am I talking about? Let's first of all look at slow transit. So this is a very non-clinical study. This is the last bit of theory I'll present. 24-hour study from 2 o'clock one day to 2 o'clock the next day. And you can see that this is a probe passed via the anus, measuring pressures colonoscopically throughout the colon, multiple manometer points. And you can see that there are peristaltic contractions going from the right colon down towards the left, sometimes coming all the way down, sometimes stopping short. And they are clustered after lunch, after dinner, and after breakfast. And when you go to sleep, your bowel goes to sleep. Here's a patient with slow transit. All of that postprandial activity is lost. Lots of red contractions, i.e. retrograde contractions. No postprandial activity, lots of nighttime activity. And so you can see that the symptoms that this person is going to have, there are 2 symptoms. One of them I've already shown you about, hard stools. The longer material stays in the bowel, the more retrograde contraction there is, so the stool gets drier and harder and pellety. The second one is infrequency of opening the bowel, of urge. Not how often do you go, because patients will often try, but they don't get the urge, the call to go to the bathroom. It's less than once every 36 hours. So if you have those two symptoms, infrequent urge and hard stools, you are 99% guaranteed to have slow transit. So you don't have to do a transit study, you don't have to do anything complicated. You can just ask those two questions. If they're positive, that person has slow transit. But transit and evacuation are related. We mustn't think of, not everyone who has slow transit doesn't have evacuation problems. Sometimes they can coexist. And here's some more data from that same study that we did, looking at the relationship between transit and defecation. So it's a study where we looked at, if you look at this graph, beginning at time 0, that's the time of defecation, and then going back in 30-minute intervals to before the bowel act. And what you see in a healthy individual, that person on the top of that slide, is that in that 30 minutes before a bowel action, there's lots of contractions. Whereas in a patient, there is much less contraction. So when they try and go to the bathroom, they haven't got any peristalsis bringing material down. So this patient will have difficulty in voiding. And we then have to consider the problems that can occur in the pelvic floor. What are the symptoms that we can recognize in the pelvic floor? So the commonest structural problem we'll see is erectocele in women. And this is it's a proctogram. Again, I'm not suggesting that we do proctograms. What I want to show you is just how you can ask questions to understand the symptoms. So the pathophysiology of slow transit, you understand the symptoms. The pathophysiology of erectocele, what is it? Patients will get the urge to empty, but because the stool fills up in the back of the rectum, and they get this feeling of a lump in their vagina. They get a feeling that they want to support and splint their perineum, to lift up the perineum here, to try and push upwards where the black arrow is, to try and help them empty. Sometimes even they need to pass a finger or thumb into the vagina and push backwards. So these are things that we may find awkward to ask our patients, but if you do, you don't need to do any complicated tests. If we can break down these symptoms, we can understand the pathophysiology much better. So you can understand the rectocele symptoms, I hope. And then the other second commonest structural thing that you can see in about a quarter of patients with constipation who present to a hospital setting is interception. Again, here shown on this graph, but the proctogram, what it's meant, the symptoms that I want you to think about here, these patients will complain of one thing. They get the urge to go like normal, but when they go, only a small pellet will come out. And then the more they strain, the less comes out. So they stop straining and they give up. But as they give up, the interception is reduced and more comes down. But then as they strain to push that out, a pellet comes out, but then they get stuck again. And so they have this thing of going up and down the toilet. And again, these are symptoms that we may not ask very often before, but now we can ask those questions and understand whether this person had interception or erectocele or slow transit. And then much more common in the structural problems are the anismus or outlet obstruction or obstructive defecation. Any of these terms have been used, where the puborectalis does not relax. You know about this. I won't tell you stuff you already know. So the puborectalis, instead of at rest, creates a nice anorectal angle and is associated with the anal sphincter. And when we strain, all of that should relax. The sphincter should open. The angle should straighten out. But we know that in dyssynergia, that fails to happen. And so the patients here will get a need to anally digitate. They'll get a sense of incomplete emptying. They'll strain. It's unlike interception, straining is successful, but they need to strain to empty. So again, I say the symptoms can help us understand the underlying pathophysiology, because I don't believe we need to do tests. So this is a figure that we helped produce for the European Society, which says that actually the place for testing is shown with the arrow here, is right at the very end. Only after we've understood symptoms, tried to understand the mechanism, tried to make first-line relief, and only when you fail do you need testing. So this is not a talk which says, do a proctogram, do a transit study, not at all. This is a talk which says, ask the questions and understand the pathophysiology. And then when we come to treatment, what can we actually do? What's the evidence base that supports our treatment decisions? Well, this is something you know from medical school onwards. There's lifestyle, laxatives, and the alternatives. What are the lifestyle things that help? Well, I'm going to present some data on fiber, but actually the benefit for fiber in people with slow transit is 0, and it really only helps those who have normal transit. Increasing activity and increasing fluid intake, very little evidence of any benefit, and I'll present that in a moment. Where there is much more benefit is the idea of training patients to use the toilet in the correct way. So get into a routine, not to ignore the urge. So get a routine, don't ignore the urge, use the correct position, Don't spend too long so you're straining inappropriately. And this is part of what we'll touch upon with biofeedback. And those things have got a very clear evidence base compared to doing nothing of benefit. Now, let's look at this. I mentioned I'd show you some data on exercise. So this is data on exercise, and it tells you that to get an improvement in this study from Japan in constipation, you have to do more than 4 hours of walking a day, which of course no one is going to do. So exercise cannot increase the motility of your gut. And when they tried to do a randomized controlled trial of this, they couldn't recruit patients enough. And again, it requires massive amounts of exercise. And actually, the reason is that exercise is complementary with fiber. So this is the famous Nurses' Health Study, massive study from North America, and it divided patients in terms of constipation risk into quintiles of how much fiber they took and how much exercise they took. So the lower the number, the less fiber you take in 1 here compared to 5 here, and the lower the number here, the more exercise you took. And what you see is that if you are somebody who takes very little exercise in the back right bar here, the back left bar, sorry. If you take very little exercise and take very low fiber, you have a very high chance of having constipation. But any one of these things on their own, if you can take a lot of fiber over here in the front in the white bars here, a lot of fiber, but if you don't exercise, your risks of constipation are the same as if you take no fiber at all. So the point I'm trying to make with this famous study is that the benefits of fiber are only seen when you do with exercise as well. But the other important thing is that fiber only helps if you have normal transit. Because fiber, how does fiber work? Fiber works by a chemical way through fermentation and a physical way by trapping bile acids and bile salts and other components of indigestible material. And what's important to recognize is that this physical effect is almost maximal by the time you get about 5 grams of fiber in your bowel. When you increase fiber artificially with medication or asking people to take more fiber, all you're doing is producing more fermentation. So you get more gas, more bloating, and actually you can make patients with slow transit have much worse symptoms. So most patients already have tried fiber, and giving them to take more fiber, especially if they have slow transit symptoms, is of no help. So in some ways, this first part of this talk is to say most of lifestyle things are not very helpful. Toilet training, toilet habit, getting into a routine, those things are useful in terms of the conservative therapies. And ditto, fluid intake, very little benefit on its own accord. You know, if you dehydrate a healthy individual, yes, then you'll get reduced stool frequency. But a constipated patient is not dehydrated. Constipated patients, if you give them extra water, they can't magically hold it in their bowel. They just pass it out as urine. So increasing fluid intake for constipated patients makes no difference to their bowel frequency, no difference at all. So don't waste their time telling them that. So if we move then to the next category of treatment, laxatives. Laxatives, where you look at this same graph from the previous study I've shown you, you could say, well, maybe laxatives don't help because whether the patient takes laxatives or not in different countries, they get the same. The height of the bar is the same for blue and red. Yes, different countries have different frequency. The Italians seem to have more trouble than, say, in the UK. But in each country, the bars are exactly the same height. So does that mean laxatives are no good? No. I think that means that laxatives are useful, but that we as doctors don't use them the correct way. We tend to use them by saying, I always use this one or that one. And that's the wrong message. What I've tried to do so far is tell you that the different pathophysiologies will help us understand the symptoms. And now we know the pathophysiology, we can then use that to tailor the therapy. Because when you ask patients what they think, why are they unhappy with laxatives? This is a study that we did a little while ago. They are most unhappy because we don't help their bloating. And that's the thing that's most troublesome. Bloating, straining, gas are the things that most trouble our patients, not how often they go. So the insufficient help of multiple symptoms and they're not relieving bloating are why they're unhappy. And drugs are unpredictable. Now, why are they unpredictable? They are unpredictable because all laxatives work through a contact action. The more time the drug makes contact with the mucosa, the more of an effect it has. That's obviously true for the drugs which bind water. So the fiber agents and the sugars like lactulose or fibergel and things like that, because obviously the longer they're in the lumen, the more water they join. So they're contact agents. Then there's the drugs like docosate or paraffin, which act like surfactant coating the lining. And of course, they depend on contact. But even the drugs which affect peristalsis, like Senna or bisacodyl, they are also contact agents because to be activated, they need to make contact with the brush border enzymes in the small bowel or with colonic bacteria. And so they depend on contact time to be activated. And that contact time is variable. Sometimes it's normal, sometimes it's too quick, sometimes it's too slow. Sometimes patients therefore will end up with diarrhea on the same dose as constipation. And the reason we now understand that mechanism. So we need to think about these agents differently. So if we went through all the 150 odd randomized trials there are of different laxative classes, and I tried to summarize these here, the number of studies. And what you see is that bulking agents help people with dysynergia, you know the symptoms by now, and with normal transit. I've already presented that to you already. So it's not about bowel movement frequency. It's more about selecting the right patients. So dysynergia and normal transit, use a bulking agent. Stimulants help patients who have the occasion, they're okay sometimes, but then it gets a bit slow for a while. That's when a stimulant, bisacodyl, picosulfate, Senna, can help. And also in elderly patients, it's helpful in that particular group. And if you look at the osmotic agents, there's data for lactulose showing it helps in slow transit and in patients with impaction. And then if you look at the PEG agents, here's data from macrogol with electrolytes, again showing that it helps in the elderly, it helps to improve stool frequency when it's infrequent, it helps in slow transit, helps to reduce straining. So again, you can select out the patients you help most to get a difference, not by selecting just the same agent, but by asking the patient the symptoms. Now, what's the difference between the different agents? And I'm aware that Asino are introducing macrogol, Movicol to Iraq, and I'm happy to present some of the data of our experience as well as some of the data in the literature. And if you compare it with the existing main osmotic agent, lactulose, there are 9 studies. And some of them are neutral, half of them are neutral, but 4 of them favor the macrogol preparation for frequency and consistency. And even in pain, there's only one study which favors lactulose, and that is a very small Bulgarian study. The other ones are either neutral or favor the osmotic effect of macrogol PEG and electrolytes, basically. So the advantage is certainly there with the macrogol, and we use almost no lactulose in our country outside of liver settings. And the other issue is in terms of there's in a so randomized study here, it's important to see that there's a clear separation, not just that it's better tolerated, it's also a more effective agent in terms of likelihood of inducing success. And this is a meta-analysis from a variety of studies where you can see there's unequivocal improvement in the meta-analysis in favor of the PEG agent. And the other big place that we have for Movicol is in use for disimpaction, a very common issue in our experience, which is often missed out on and overlooked. And here's an important study published comparing PEG with enemas and suppositories and manual evacuation. So the 3 main therapies of disimpaction. And what you see is that all of these agents are effective, but disimpacting within a short period of time is most effective with macrogol. So in terms of cost efficacy, not having to bring people in for expensive evacuations or put them on long-term therapies via the back passage, which they may not like, in terms of timeliness, PEG has an advantage. And in terms of reducing hospital consumption and occupied bed days, there's a big advantage for the PEG macrogol version over the other existing agents. So for us, that's been the cornerstone of why we use macrogol for disimpaction. Now, the compound you'll hear more about and from colleagues locally, but I would like to introduce the idea that this is an agent which certainly has changed our practice in the UK in terms of how it's used. It's essentially a pegylated electrolyte solution, which causes a slow, sustained effect to improve patients with slow transit and symptomatic constipation. So here's our use of various agents. Movicol is shown in the red bar, and it's our single largest used agent in the UK by quite a long way. And the summary of the message, to go back away from the talking of Movicol to the more general points, is that we need to think about the patient's symptoms, translate to pathophysiology, and then use that understanding to choose the treatment. And so these slides I'm very happy to share, but essentially they try and show this summary of this meta-analysis we did of all these various randomized trials of laxatives, showing that you can select out the group who should have particular therapies as first line and then second line therapy over on the right hand side. So what I want to try and present to you, the idea is that not to have a single favorite agent, but to use the right agent for the right patient, and bear that in mind if you, in terms of helping the patients. Now, we've gone from those very non-specific contact agents like laxatives. You'll have sometimes met some of these neuro agents which are tailored to particular targets. There are drugs like prucalopride which target the 5-HT4 receptor and thereby increase acetylcholine in the bowel and therefore increase peristalsis. There are drugs like alvermapan and naloxegol which target the mu receptor in patients who've got opioid-induced constipation. And these are all drugs which are licensed to us in the UK and maybe not there, but they're coming around the corner for you in the future, no doubt, in terms of therapies, but only when laxatives have failed. Drugs like lubiprostone, which works on the chloride channel directly, and like lactitide, which work indirectly on the chloride channel to increase secretion in luminal water and therefore improve constipation. But these drugs, they're much more targeted for sure, but they're only licensed and indicated for when laxatives fail. And even when, and that's why is that? If you compare the prucalopride, the most effective of those agents, with macrogol, with PEG, this is an important study. And what you see is that actually, if you just do it blind without using the laxative refractory patients, more patients respond to Movicol than they do prucalopride. So it's not that. So the place for these more expensive, modern, newer drugs is only when laxatives fail. They don't perform as well for the normal patient as simple Movicol does. So I want to finish off, if that's okay with you, by having talked to you a lot about the practical aspects of assessment of symptoms and then translating that to therapy and trying to be practical about laxative use and then mentioning the newer prokinetics. I want to talk about three particular scenarios of constipation, if I may. One is a scenario around pregnancy, the patients with megacolon, and then opioid-induced constipation. So pregnancy. Well, the key thing here is to tell the patient that they're doing no harm to their fetus or to themselves. They don't make their pregnancy more complicated or their delivery more complicated. This is a situation where things are different, though. Fluid intake definitely makes a difference from the randomized trial. That's absolutely clear. Fluid intake, because these patients have got a much larger body volume, so optimizing fluid intake is really important there. Nearer 2 liters than 1.5 liters. Fiber supplementation also has an effect here. These patients tend to be much more sedentary, so you try and augment the fiber as well if you can. First-line therapy, if that fails, is to use PEG, Movicol. That's first-line drug therapy if they are refractory to the lifestyle advice. And if that fails, or you haven't got it available, then lactose is the second-line therapy. So that's the situation. Reassure the patient, lifestyle things do make a difference here. And then if that fails, then PEG. Pediatric constipation, again, this is data which you'll probably mention that alongside the pregnancy. But remember, a large part of the pediatric burden, a lot of these patients have behavioral issues. So you think about whether there's any encoparesis or soiling behavior or stool withholding behavior in young children, and then use that. But again, the key point here is that if you need laxatives, mainstay of laxatives, once you disinfect them how? With PEG, and then maintain them with PEG. So PEG is the reason it's got such a big market share in the UK is because it covers a variety of bases. Now, this is a condition called megacolon, which you'll have seen, and you may be thinking it's rare, but actually megacolon is very, very common, I think. One in 1,500 live births has a megacolon. It's a much more common scenario than we think. 1 in 1,500 live births. So we estimate that if you see 200 patients with constipation a year in a typical population, you will see at least 2 megacolons coming through. Now, I suspect most of us don't diagnose 2 megacolons a year, but they're there in our patients. And this is a patient with a massive rectum. Look at this rectum. It's rising out of his pelvic floor. And he's not a disabled child. This is an 18-year-old boy who I just took a slide off about 2 weeks ago and just to put on for this slide, who plays hockey for his region. So he's a really active boy. But his symptoms are that he has very infrequent urge, very infrequent stool, massive stools, and lots of soiling. These patients have a dilated rectum, a flaccid anal canal, and they soil. And we have to ask those symptoms. And then you palpate the abdomen, you feel this huge fecal bolus. This is not that unusual. So we'll pick up about 4 or 5 a year of these children or young adults, and they always have this issue, and they find workarounds. So you have to ask about soiling because they get used to wearing pads or changing their underwear or having lots of perfume around them, and you have to ask the question and think about this. And most of these patients can be managed without surgery. Again, when I was training, we used to think, well, if you diagnose this, number one, it's rare. Well, it isn't that rare. Number two, you operate on them. But actually, the data, if you look at all this, is that most of these patients can be managed medically. Only a minority, only about a third need an operation. And then if they do, that's an rectal. But how do you manage them? You bring them in, you disimpact them, you train them to use an osmotic laxative so that they have 2 bowel actions at least every day, and they just adjust the dose. And sometimes they need 8, 10 sachets, 12 sachets even of Movicol a day, but they must have at least 2 bowel actions a day, semi-formed, and sometimes we also give them some biofeedback to help improve their rectum. Now, opioid-induced constipation, increasingly a common problem in the Western world, maybe also in Iraq, where opioids are now being used even for benign pain. Previously, they were reserved mostly for malignant pain. They're now being licensed in the WHO pathway for benign pain, and therefore we're seeing a huge increase. Maybe 3%, it's estimated, of the UK population are on regular opioids. 3% of people, that's an enormous number. And of course, opioids attack mu receptors and cause constipation inevitably. And again, there's some good randomized controlled trial data comparing these newer agents like naloxegol, the opioid receptors, pamoras, these so-called peripherally acting mu opioid receptor agonists, so pamoras, and patients prefer the PEG effect because it doesn't cause so much contraction, doesn't cause so much brain fog. It has a purely peripheral effect. So yes, pamoras have changed the game, but always use a PEG first, and if that fails, then think about pamora. Now, I was asked to make a couple of comments about biofeedback more generally. So moving away and just talk about other therapies. Biofeedback, I think, is a really important thing. So the first and most important part of biofeedback is the toilet training, the getting in the right position, getting to a routine, and our staff spend a lot of time getting patients to think about that and learn that. But then there's some actual biofeedback involved. There's the rectal balloon. In the American version, you also have electrodes on the sphincter to teach relaxation. And then that combination of the rectal balloon giving sensation and gradual desensitization or resensitization if they're insensate or hypersensate can be done alongside electrode sphincter EMG to give biofeed, to actually give true biological feedback to the patient to consciously use and change. We and many other groups in Europe have shown that actually the electrodes make no difference. They make no difference. Simple balloon tied to a bit of tubing connected to a syringe can be used for the balloon part, for the sensation, and then for the evacuation. And that is enough for most patients. And biofeedback is a really key part for us. But also biofeedback, apart from the bowel rectal dynamics and the toilet habit, also addresses the aspects of traumatic childhood, the social coping mechanisms, and the emotional traumas that patients often experience in their life. So biofeedback is a kind of holistic therapy which addresses a lot of these other areas. And actually the balloon stuff is a minor part, and a really minor part of the sphincter stuff. In fact, we don't use the sphincter EMG electrodes at all in any of our patients for the last 2 years. We just don't find it useful. It doesn't add any extra response. Finally, got to mention colectomy. We're cautious about colectomy. Patients have to be obviously emotionally stable. They have to have normal small bowel transit. There's no point doing a stoma or doing an rectal if the patient has small bowel transit because they remain constipated. But the thing to remember is that the longer you follow up patients in these studies, the less satisfied they are. In fact, these studies where there's near 39% satisfaction are the ones which go on to 5 years. Most of these studies declare their data at 12 months. And even there, 15% of patients are not satisfied. They wouldn't have the operation again. That's a big number. 1 in 6 patients going through a colectomy would not have their operation again. And that's a real problem at 1 year. And at 5 years, it's 60%. So we are very careful. Patients have to be emotionally stable. If they have pain, we never offer them surgery because pain does not get better with a stoma or with an ileorectal. You've got to counsel them that 1 in 7 of them, 14%, will go on to get diarrhea. A different 14% will go on to have incontinence. 10% will stay constipated. So this is not a cure. Okay, this is not something which we can say take lightly, just do it if everything fails. We have to be much more serious about this. So I hope I've presented a few ideas for you to think about in this area. Number one is how symptoms can help us understand the patient's underlying physiology better, how that can then in turn choose our laxatives better, how in particular the use of, from our experience, Movicol can help a variety of situations, which I hope, and again, feel free to ask any questions I've not been clear about, and then the adjuvant therapies and the particular conditions that are worth considering. That's a lot to talk about. 25 minutes to spend talking about constipation means that I've covered a lot of areas, and I'm sorry if that's been too quick in some areas. I said this, I'm very happy to share the slides, and please do ask me any questions along the way that come up. And thank you very much for the invitation. Thank you for your time, and thank you to senior colleagues.
Thank you, Dr. Anthony. We would like to remind our guests, if they have a question, please type it in a question and answer bar, and we will answer them during question and answer session. Our next speaker is Dr. Ali Al-Saidi. He's a gastroenterologist at the Gastroenterology and Hepatology Teaching Hospital, Baghdad. His talk is about practical points for constipation. Dr. Ali, the mic is yours. Many thanks, Dr. Ali, for your nice presentation. Ongoing.
Thank you, Dr. Jassim, the Iraqi president of gastroenterology, for this introduction. Thank you, Asino, for this opportunity for this meeting. And I would thank to Professor Anton for his lectures, and I hope that this is the first communication with the London, and to try to more cooperation in the near future. I would like to share with you my slides now. Okay, is that clear?
Yep.
Practical tips for constipation. Why we have to treat constipation? Yes, most constipated patients, they have abdominal pain, bloating, abdominal distension. All these are cumbersome symptoms, really. But actually, we have to think as a gastroenterologist beyond the box. We have to think about the underlying diseases that can be hidden behind constipation. So before starting giving treatment or any form of laxatives, we have to think what is the underlying constipation, and if there is any sinister diseases that can precipitate the symptoms. First of all, we have to take some history point, which are important. Dr. Antonio already gave a lot of information about dietary habits and low and high fiber content of diet. But I want to spot the light about gastrocolic reflux, which is once the patient starts eating, there is this part induced peristalsis and induced bowel motion. So some patients say that we are not taking food for days or for some hours, they do not pass motion, and that's a little bit is true, because taking food will already start peristalsis, stimulate peristalsis, and stimulate gastrocolic reflux and prevent constipation. Also, this is a very important point to have an idea about if there is a slow transit or normal transit for the patient. As Dr. Antoni said, two questions very important is the presence of hard stool. The consistency of the stool is very important to know. If the stool is hard and difficult to pass, this is mostly due to slow transit. And if there is no tendency for the patient to pass to the toilet, or they even do not sense the urge to go to the toilet, this is two clues, important practical clues, that the patient already has a slow transit. In contrast, patient with normal transit usually has normal stools and a daily urge for defecation. Also important point in history taking is that some patients already use their fingertips in order to digitally extract the stool from their anus and in order to empty the rectum. This gives a clue to the presence of defecatory disorders, where the stool is already in the rectum but the patient cannot push the stool outside in order to get rid from this feces. So he needs to do a lot of training and to digitally extract the stool. This is mostly due to defecatory disorders. There is also an important clue for the idiopathic megacolon, which is a really common condition and frequently seen in our practice. The presence of fecal impaction and fecal soiling, because the stool remained for a long time in the colon, so all the fluid content has been absorbed, and the fecal becomes so hard and difficult to pass. And since the feces already present in the rectum, it causes fecal soiling, where some feces can be present in the underwear. Although this is not specific for idiopathic megacolon, but it could be one of the clues for this diagnosis. Examination is also important in order to find any incisions inside the bowel, inside the abdominal wall, because the presence of a lot of incisions may indicate that there is adhesions which can be responsible for the slow transit or responsible for the constipation. Also, we have to take into consideration the presence of other medical diseases like thyroid disease, diabetes, renal impairment, and hypercalcemia. And we have to direct investigation towards these conditions, especially diabetes mellitus, which can be hidden, and therefore sending the patient for glycated hemoglobin or thyroid function test, renal function test, and to check their calcium level. Many patients visit many doctors, and many rheumatologists and orthopedicians, they prescribe non-steroidal anti-inflammatory drugs or opiate medication, as we can see there. And just stopping this medication may be the only valuable treatment. Also, another patients visit neurologist, and they prescribe antiparkinsonians and phenothiazine, tricyclic antidepressant for depression, and all these medication can cause constipation. Maybe the only treatment is just to stop this medication or replace this medication with other drugs that are less constipating. Also, physicians can prescribe calcium channel blocker, antihypertensive medication, diuretics. We have to be careful about all the medication that the patient take in order to discuss whether stopping certain medication may get a total benefit for the patient. I would like to spot the light about malignancy. Malignancy is an important issue, and any patient with constipation should we think about the presence of malignancy. There is red flags, which is common to know for every physician, and these are bleeding. Bleeding in our institute and in many institutes worldwide should raise the suspicion of malignancy. And now it's recommended that every patient with a bleeding per rectum, even in the presence of a clear presence of hemorrhoid or fissure, should undergo at least sigmoidoscopy in order to exclude the presence of a proximal polyp or proximal malignancy. And another important red flag is the weight loss. Weight loss is clearly a sinister symptoms and should be taken into consideration. A very important is change in the stool caliber. Change in the stool caliber is very important and may indicate that there is a constricting lesion, decreasing the lumen of the colonic lumen, and thus causing change in the caliber of the stool to pencil type. Especially if this is so recent, should raise the suspicion of the presence of malignancy or constricting type. Obviously, old age, especially patient more than 50 years, or the presence of family history of colon cancer also should be taken as a red flag for early diagnosis of malignancy and to search for. Why this is important? Because if we find a small polyp in the colon early, this polyp can be removed easily by using a snare and removed endoscopically without the need for surgical intervention. If you look here, this polyp, if left without diagnosis, this polyp will increase in size, although it can also be removed endoscopically. If the polyp is not discovered at this stage, the polyp will be increasing in size more and more and will be more difficult to be removed endoscopically. However, it is still feasible. Also, the risk of complication will increase. If the polyp cannot be diagnosed at this stage, it will start to invade the colonic wall and to extend more than to extend to extend to include more the surface, more the circumference of the colonic wall. And at this stage, it cannot be removed endoscopically and carry the risk of metastasis. And if left and not diagnosed at this stage, we can see that there is circumferential constricting of the colonic wall, and there is colonic lumen, and we can see that the stool change of the caliber can be noticed here because there is constricting a tumor that can change the caliber. And in this stage, we may miss the patient because it may metastasize or need surgical intervention, and there is a really sinister outcome. So what to do to exclude malignancy? As we know, colonoscopy is still the gold standard. However, not any patient accept to do colonoscopy because of the bowel preparation, pain may encounter during the procedure. However, there is another modalities for screening, which is fecal immunohistochemical assay. And in Iraq, we start a new project to implement fecal immunohistochemical assay for the screening of patients more than 50 years old to detect malignancy. And the benefit of this is that it can differentiate between human RBC and animal RBC, and therefore there is no limitation of the diet intake before the procedure. Also, as we see here, it's a very simple procedure and can be done by the patient himself, physicians, or even the lab. It's a very easy procedure. There is another modality for screening colon, for screening of the colon for the malignancy is virtual colonoscopy. Virtual colonoscopy can give a very nice and clear image for the whole colon and can detect the presence of polyp. However, it still needs bowel preparation, almost similar to the bowel preparation needed for colonoscopy. And in addition, it is not so practical in screening program because the patient will expose to a lot of radiation in a short period of time. So it still has its limitation. Fecal occult blood is really cumbersome, non-specific, it cannot differentiate between human RBC and animal RBCs, and it's really out of favor in these times. Just a few note about fecal immunohistochemical test. It is a change in stability according to the company that can be stay for 8 days for certain companies to 14 days. And the detection level is also differ from company to company. Therefore, we have to take care for this. The benefit of this test is there is no dietary restriction, no need for the patient to stop meat or any form of diet restriction. It's convenient and fast and private, and it can be used by anyone, anytime. But the problem with this test is cannot differentiate from where this RBC comes. So it cannot differentiate between colorectal cancer, whether it's polyp, whether it's diverticulitis, colitis. So it's only detect the presence of our human RBC, but still we need colonoscopy to know what is the reason behind. This is an important issue is the idiopathic megacolon. Idiopathic megacolon can present as a constipation. It can also involve only the rectum or the whole colon. Still, constipation with infrequent urge to defecate is common to both. Fecal soiling is more common with megarectum. Fecal impaction and overflow incontinence, as we said, are the main complication. How we can differentiate between this common condition and from Hirschsprung's disease, which is a condition, hereditary conditions, especially seen in children, but both of conditions associated with increasing the colonic lumen and the colonic size. This is very practical point and important to remember, is the presence of, is the absence of lifetime complaint since patient with megacolon or megarectum is usually kind of present in adolescence and in old age, it does not does not start from childhood. The frequent report of fecal soiling, as we said, that fecal soiling and is due to the presence of the stool in the rectum, so it can pass through the anus to soil the underwear. So presence of stool in the rectum can be felt by per-rectal digital examination and can present as a fecal soiling. This is important tips to differentiate between idiopathic megarectum and megacolon from Hirschsprung disease. But one of the important things that can differentiate between the two conditions is the barium enema. There is a very nice radiological clue that can differentiate between the two conditions. In cases of megarectum or megacolon, there is hugely dilated rectum, but this hugely dilated rectum will end into the normal caliber colonic lumen. So start very long, very large, very dilated mesorectum, and go back, we can see proximally there is normal caliber colonic lumen. While in Hirschsprung disease, the condition is different. We can see there is constricting lesion in the rectum, and this constricting lesion is followed proximally by a dilated colonic lumen. This is similar, constricting lesion and very dilated colonic lumen. So we have constricting and dilating lumen here. We have dilated lumen with normal caliber colonic lumen proximally. This is an important radiological clue for differentiate between the two conditions. I have a question in order to further use the history in order to know what is going on and how we can treat the patient according to the clinical history. This 40-year-old female with long history of constipation. The patient used to strain for hours in toilet for defecation. This is actually a very bad habit to spend a lot of time in toilet, because straining is usually lead to complication. Complication in the form of not only inducing hemorrhoid and inducing rectal prolapse, solitary rectal ulcer. So I advise most our patients not to strain a lot, not to spend a lot of time in the toilet, and once they need a lot of time, and even if they feel incomplete defecation, they have to stop being inside a toilet and go out and to start seeking another medication in order to solve their problem, because excessive strain and spending a lot of time in toilet usually lead to complication. So this young female with long history of constipation spent a lot of time in toilet for defecation. She presented with diarrhea, fecal soiling, and occasional bleeding per rectum. Colonoscopy was arranged and shows a really big ulcer. This ulcer is at the rectum, just a few centimeters above the dentate line. As we said, fecal soiling is not specific for a certain disease. Any disease in the rectum can cause fecal soiling. Rectal tumor, solitary rectal ulcer, any disease, even ulcerative colitis can present with fecal soiling. So any disease in the rectum can present with this complaint. This patient has a very large ulcer, most likely due to solitary rectal ulcer. This condition is very important and is one of the complications of long-standing constipation and the complication of excessive straining, because excessive straining can cause ischemia to the mucosa and therefore inducing ulcer. This solitary rectal ulcer is a misnomer because it can present with multiple polyps. It's not solitary, it can be multiple. And we can see in this picture, it's a lot of multiple polyps can present here. And this is also solitary rectal ulcer, which can be misdiagnosed as rectal polyps. Or also can sometimes mistaken for a polypoidal tumor. We can see this, a large bulge in the rectum, which can be mistaken as a tumor. However, this is a really damaged mucosa and granulation tissue leading to formation of tumor-like projection. This ulcer is very ugly ulcer, which is really suspicious for malignancy. However, this is another form of solitary rectal ulcer. Another example. So solitary rectal ulcer is a misnomer. It is neither an ulcer, could be present as a polyp or tumor-like. It can be multiple, and it is really a miserable disease. Is difficult to treat, as we said. It is really miserable. It's caused by straining. Therefore, straining is a very bad habit. Has many endoscopic appearance, difficult to treat, and the best treatment is to stop straining with biofeedback. Some cases of solitary rectal ulcer present with bleeding, and we successfully treat those patients with organoplasma coagulation. And actually, organoplasma coagulation is not only stop bleeding, it is stimulate the local vasculatures and even induce healing. And there are many cases of solitary rectal ulcer, which is treated by organoplasma coagulation. And in the follow-up, we can see there is a really dramatic change in the diameter and in the size of these ulcers after 1 or 2 sessions. So we have to keep this possibility in mind. Another case study, this 30-year-old male presented with abdominal pain, constipation, and obstipation with abdominal distension for the last 2 days. Abdominal X-ray was arranged, and this is the X-ray. So we can see multiple fluid levels inside the abdomen in this plain abdominal X-ray. So constipation can be associated with a really serious condition, such as abdominal obstruction. Therefore, we have a clinical judgment and adequate examination is highly efficacious in determining how to deal with this patient. Constipation, abdominal intestinal obstruction can be associated with a lot of underlying causes. Some of this carcinoma, adhesions, obstructive hernia.
We can manage and go to Dr. Ali. There are 2 questions.
Yeah, sure.
Dr. Ali, what if we cannot stop the medication that are causing the constipation? You mentioned some drugs that can cause constipation. One of the questions. Do we have the incidence of Hirschberg disease in Iraq? This is for Dr. Ali.
Yes, actually, we have to do our best to change the medication to another form of medication that are less constipating. However, if there is no choice other than using this single medication, we have to try to decrease the dose as much as possible that are less causing less effect. And in this situation, we can use other modalities for treatments like laxatives. Movicol is one of the choice that are less problematic in this condition because it is osmotic laxatives and cannot cause a problem. However, many medication can be replaced by other form of medication that less constipation, such as the antihypertensive medication, those with non-steroidal anti-inflammatory drugs. All these can be replaced by other forms which are less constipating. However, in certain conditions where there is no other choice, we have to take the medication anyhow.
Next question: how do we have any idea about the incidence of Hirschberg disease in Iraq?
Actually, I don't have a special idea about this, the incidence of the disease. However, we see some cases that are treated surgically in our center. But exact numbers of cases and the incidence, I don't have an idea.
Yeah, because most of them, they are treated by the general practitioner and by their family. Some of them reach up to 17 years old and he didn't know the cause of his constipation in our Iraq.
No.
Now the questions thank you, Dr. Ali, for your answers. Questions for Dr. Haider. What is the maximum duration of Movicol treatment for patients? What are the benefits of Movicol versus Edulax?
Okay, thank you, Dr. Jassim. The treatment duration for Movicol, actually, we have as a company studies for long use of Movicol for up to 3 months as a company. So we can say that the Movicol can be used up to 3 months. It's safe to be given and the patient doesn't have adverse event. However, if we go some kind of study that are not performed by the company itself, it's like a retrospective trials performed by third parties, we can see that the Movicol is safe to be given up to 2 years. So what we have as a company to say that Movicol can be used up to 3 months, continuously, of course. And for references other than from the company, we can see that Movicol can be used up to 2 years. The benefits of Movicol versus the combination of Spargula husk and Senna, the product that you mentioned, Doctor. Actually, it's obvious that for the products that contain a combination of Spargula husk and Senna, we cannot use it for long term. We can use it, yes, for a short term to have intermittent use. We can use it in that way. However, for long-term use, it won't be a good idea to use a stimulant laxative for a long period of time because it will cause irreversible damage to my enteric neurons. Additionally, since it contains Senna, we should avoid it in the first trimester of a pregnancy, while Movicol can be used in all trimesters of pregnancy.
Thank you, Dr. Yahya. Another question. Can be used Movicol as for the preparation of colonoscopy? Is it pediatric or in Iraq?
Okay.
You answered the question, can be used Movicol for long duration or have limited time duration dosage.
Okay, so about the duration, we mentioned about the duration of treatment. We can be used up to 3 months. For preparation of colonoscopy, actually,
I have used it more than 5 months.
For me. Okay. Yeah, we had that practice, but as a company, we should rely on the data. But yes, it's safe to be given since it contains electrolytes and an osmotic one. For preparation of colonoscopy, actually, polyethylene glycol as a molecule, it can be used as a colonoscopy, but not in the dose that is present in Movicol, because the dose in Movicol is actually 13 grams. The dose of polyethylene glycol for the preparation of colonoscopy is actually 60 grams. So we don't prefer to use Movicol, and it's not approved to be used for preparation for colonoscopy. That's out of the range of our Movicol indication. However, some physicians reported that they use like 4 or 8 sachets of Movicol to induce that. We don't prefer to be that. It will be enough label, to be honest, use. It is not to be used with colonoscopy. For pediatric formulation, Movicol can be used since age of 1. It's present at a dose of quarter sachets per day for those with 1 month to 1 year in the British National Formulary. So it's safe to be given even starting from 1 month. However, unfortunately, for pediatric dose, we still don't have that dose in Iraq. But yes, you can adjust the dose. You can divide the Movicol dose into 4 quarters. You can use them 1 quarter 1 or 2 times daily for patients or for children from 1 month to 1 year. And the exact dosing for Movicol is present and actually mentioned in the British National Formulary. So I can say, yes, it can be used from age 1 month and above, but it needs dose adjustment.
What is the price?
I have a comment for bowel preparation in children.
No.
Usually we use the same formula for adult, and we ask the parent to stop giving the patient or the child bowel preparation once the stool become clear, so clear. Then he can stop the bowel preparation. So the same formula, use 1, 2, 3 sachets, whatever the manner, but our goal is to get a clear stool. This is the best way.
Okay.
Thank you.
What's the price of Movicol for Iraqi patient, Dr. Haider?
The price of Movicol for Iraqi patients is approximately 1 packet contains 20 sachets. approximately 18,000 Iraqi dinar 18,000 دينار للباكيت الواحد اللي هو تقريبا it will be sufficient for our patient for if we say 1 by 2 for 10 days, which is their usual standard say course for treatment for initiating the Movicol.
What is the test of Movicol? I have tested it. It is better than anything. Me
Yeah,
test.
okay, thank you. Thank you. Thank you. It's
What
actually a lemon and lime.
about
We will update the artwork.
acceptable?
Yeah, it has a little bit of sodium bicarb, but it is tolerable. Usually we can see that there is no bad taste, such as if we can compare it to lactulose or some kind of bulk forming. It have an acceptable taste for most of our patients. Yeah.
What about Dr. Antonio? Is he on the online or not?
I called Dr. Anton. He had an emergent endoscopy surgery. He answered most of the question by typing them. If you want me to go through them, or I don't know, Doctor, up to you. If you want me to read them and read the answer of them, because he typed them while we were speaking for those who answered them. But however, if you want me to read them so that all our attendees get benefit, or we can just move on to if there's any question. Up to you, Doctor.
There are no questions apart from these questions here. Is there any study to see how much patients are actually stick to our recommendation of increasing water and fibers? In IBS with constipation, once we give fiber medications or even natural fiber aggravate symptoms such as bloating and pain, what do you suggest in such cases? Can we see combination of BEC and stimulant laxatives in the first few days? Can we use in first few days to get fast onset of action? How we manage patient with mixed type IBS, sometimes constipation, other times diarrhea. Professor Anthony, you would recommend Movicol over lactulose in patient with chronic idiopathic constipation. Movicol can be used for any age. You answer this question. You say it is since even he was 1 month age, you can give it. What is the most common side effects of Movicol? And Movicol can be used for, well, you answer this question. Differences between colon cleanser and Movicol. Is Movicol safe in pregnant women? He answered this question. So some questions can be answered by you, others by Anthony.
Yes, Doctor. I will read. I will go through the typing of Prof. Anton. So, is there a study to see how much patients are actually stick to our recommendation of increasing water? The answer, interesting question. Don't know. Bliss published a study where even when the patient knew they were being observed, less than 50% complied with lifestyle advice by 4 weeks. So even actually when the patient are know that they are being observed, 50% only stick to lifestyle. Really interesting. In contrast, biofeedback advice has been shown to be followed with up to 75 success at least 3 years after training. The second question, in IBS with constipation from Dr. Rawand. In IBS constipation, once we give fiber medication or even natural fiber, aggravate symptoms such as bloating and pain. What do you suggest in this case? Prof. Anton answered, if dietary fiber causes bloating, then we don't give supplement which are likely to exacerbate that. So if we have normal transit patient with his bloating in response to fiber, we would use second line therapy here, namely Movicol. Third question, can we use combination of PEG and stimulant laxative in the first few days to get fast onset of action? Prof. Anton answered, there is no evidence to support this, but it is logical. The problem is that in chronic constipation, speed of effect is not maintained. So we try to tell the patient to not think about speed, but rather think about prioritizing regularly. Other question you mentioned, Dr. Jassim, how we manage patient with mixed type IBS, sometimes constipation and other time diarrhea. Prof. Anton answered, most of these so-called alternans actually have IBS constipation or straightforward constipation. So many of these we manage according to constipation. Those with true alternating, less than 10% according to personal study and our experience, we manage by, as required, stimulant, viscodil or picosulfate, and avoiding loperamide unless diarrhea is more than 2 days or more than 4 times per day. So Prof. Anton, another question. So Prof. Anton, you would recommend Movicol over lactulose in patient with chronic idiopathic constipation? Prof. Anton answered, we don't use lactulose at all in this condition. He mean chronic idiopathic constipation. The tolerance, progressive need to increase dose, flatulence, and unpredictability mean lactulose is not our choice.
I have passed the event of lactulose.
Yeah.
I passed through this. Movicol can be used. What is the difference between colon cleanser and Movicol?
What's the where is it? I can see it. What age?
Differences between colon cleanser and
Yeah, and
Movicol.
Movicol. He answered, Doctor, the evidence is in favor of Movicol being safe in pregnancy. So he answered only the ones regarding the safety in pregnancy. He didn't answer the first one, but I think we answered that. The difference between colon cleanser and pharmacy, we called a purgative agent. So it will completely evacuate the bowel, the purgative effect.
Another question is the best laxatives for bedridden elderly patient with stroke?
With stroke, yes. So in this situation, he answered, we try to get the patient into a routine. We use docusate as a stool softener and glycerin suppository to avoid on a daily alternative daily basis.
Thank you, Dr. Haider. Thank you, Asino Company. There are no more questions. We hope to see you again in another conference webinar.
Yeah,
thank you.
دكتور.
Thank you for this.
دكتور علي، تعبناكم اليوم. شكرا جزيلا. وسوري لانه we know UK عندهم الامرجنسي, he should go. فسوري يعني انه our Prof Anton had to go because as I mentioned he had an emergent colonoscopy. He had to go. Patient life comes first.
Thank you. Thank you all.
Thank you all.
Thank you. Goodbye.
Bye.
Bye.
Thank you.
Goodbye.